Hey everyone, it's Nurse Danny from Intermountain Moms, and today we are at McCady Hospital with Dr. Delgado and baby Ellie. She's adorable. She was just born a little while ago. And we're here to show you what a doctor is looking for when they perform that pediatric assessment after the baby's born. What's the doctor looking for? So thanks so much for taking some time to be with us today.
No problem.
So a baby is born, they're typically assessed by a doctor within a few hours after delivery, kind of depending on the time of birth.
Right.
What are you looking at when you assess the baby?
Great question. So when I first assess a baby, I lay her down and I just look at them. And I see, how are they looking? How's the coloring? How are they acting? Are they moving all their limbs? Are they awake? Are they asleep? And just what is the overall look of the baby? And then once I've assessed that, I start from head and I go down to the toes. So start with the head. We look here at the head and feel the anterior fontanelle. We want to make sure that that's open. We want to make sure that that's flat. It's not bulging. It's not sunken. Sunken means that they may be a little dehydrated. Bulging can sometimes mean an infection. So this is nice and flat and it feels good. Also just want to look at the shape of the head. Most babies will have kind of a cone shape, and that's normal.
And that persists for how long typically?
Usually, within the first week it's fine, but after the first day even, it looks a lot better.
They come out looking kind of beat up.
They do.
And then after about 24 hours, they look a little bit better.
Yeah, so in that first 24 hours will come, and the head will look a lot better, and then it'll just keep shaping in the next week or so. So we'll look and make sure there's not any major flat spots or any lesions on the head or cuts or scrapes or anything. And hers looks great. Next thing I do is I look at the ears. I'm looking for any tags or pits, or what we call them. Sometimes you can see some tags here or some pits. And she does not have any. Sometimes if you have several tags or little pits here in front of the ears, sometimes you can have problems with the kidneys, but usually there's other things going on too. So just making sure the ears look okay, those look fine. Next thing we'll do is take a look at her chest here. Look at all of her skin. One of the things I'm looking for are any rashes.
And what kinds of rashes are normal for newborns and which ones aren't?
Yes, so there is one rash that is very, very common, and what it looks like, it's very blotchy and red, and it'll have kind of a white center. It's very common, and we see it a lot. It goes away within the first few days. It's nothing to be concerned about, and sometimes babies will have it from head to toe. It'll look really blotchy. It bothers us more than the child. It's nothing to worry about. Other rashes that we'll look for that are more concerning are rashes that if you blanch it, they don't go away, or if the baby's not doing well. But the most common rash is that newborn rash that is really blotchy all over. Okay, so as we look at her, turn her over and look at her skin on her back. You see some little blotchy areas here. That's just the newborn rash we were talking about. You want to make sure that the spine is nice and straight. Okay, and we also look down here for little dimples. If there's a dimple here in the lower back or a tuft of hair, that can mean some problems with the spinal cord. She does not have that, so that's what we're looking at there.
And then after the trunk, what area do you move to?
I listen to the heart, because I like to go head to toe and just listen to everything. So I'm listening for any murmurs. That's the biggest thing I'm listening for. And I'm listening for her lung sounds. Some babies might have fluid in her lungs, and some babies may have a murmur. Murmurs are not necessarily bad in this age, because a lot of times as the heart is changing, it changes from being inside mom to being outside mom. There's some changes with the heart. So you can hear a murmur, and it's really not a problem. I usually listen to it while they're in the hospital. If the murmur persists, we might get an echocardiogram and look at the heart, but usually it'll go away, and it just needs some time. So if we do hear a murmur, I don't worry too much. I just follow it.
So normal murmurs and then abnormal murmurs.
Right. Mm-hmm. There are if it sounds a little bit more abnormal, we'll get a picture of the heart, an echocardiogram, and we'll make sure it looks okay. And then with the lungs, just want to make sure she's getting air in and out. There's not any fluid, or there's not any decreased breath sounds. Sometimes as babies are being born, they can just retain that fluid and have a hard time breathing. So we're making sure we don't have any of that. Most babies are going to be kind of spitty. They've swallowed the amniotic fluid. It comes up, they cough, they choke, they gag a little bit. But a lot of babies want to protect their airway. And so they do. That's why they're coughing. That's why they're choking. They're protecting their airway. So that's a really good thing for them to have. And if you notice anything, they're having trouble, a lot of times you can just put them on their side here. And if you have a little bulb syringe, you see some fluid, you can just suck it out. But that's a very common thing for them to do. And once they've worked that amniotic fluid, either they've puked it out or they've pooped it out, and they're usually fine when they go home. So
after the heart and lungs, what do you move to after that?
Then we move to the abdomen. So listen for sounds here to make sure that her intestines are moving and working. So we listen for that. And you've got great bowel sounds. Yeah. I also feel for any enlargement of the liver or if there's any masses in the abdomen. So you're gonna kind of mash on their bellies. They don't like that too much, and sometimes they may spit up with it, but you want to make sure there's not any large, hard masses in there. And she's just fine. All right, let's move down. So then we get to the hips. This is a really important part of what we do. So we want to make sure that the hips are nice and stable. So kind of push down and then we push out like that. And that's just to make sure we're not having any dislocation of the hips. And sometimes in some babies, their hips do dislocate, and you can kind of feel it do that. And if that's the case, then they need to be seen by an orthopedic doctor, and they need to follow up in a very consistent way.
Or if you had a baby that's developed in the breech position and their legs are up by their face.
Yes,
right?
Yes. The higher risk in a baby that's breech is dislocation of the hips. So in the babies that are breech, we look really closely as well. So, but every single baby gets this test.
Right.
And every time we assess a baby, whether it's here in the hospital, or if it's at the 2-week visit or the 2-month visit or the whatever, we always check the hips because it can develop later.
Good.
So, and then you look at the genital area, make sure that everything is where it's supposed to be and everything looks normal for the gender of the baby. Next, I look at her neurologic tone. This is a very normal tone for a baby. They like to have their legs up. If I pull it down, they don't like that at all, and they want to keep them up. So this is super normal. I also look here for what's called a startle reflex. So I grab the baby's hands, I just kind of hold it like this, and then I let go. Okay, and she kind of does this.
Shakes down.
Yeah, and that's a very normal response for a baby. It also shows me that she's got the grasp reflex right here.
And the rooting reflex.
There's the rooting, yeah. You saw the rooting reflex. And then you also have the grasp reflex down here. You can do that, and then
their toes.
Yeah, their toes. Yeah. Mm-hmm. And while you're doing that, you just make sure that you've got 5 toes, and there's not any abnormalities here. And you look for any club foot. In a just a healthy baby, they'll have normal range of motion. Their feet will move back and forth, up and down, and it'll be just fine, just like hers. Once I'm done with that, then I want to look in the eyes for the red reflex, so I get a ophthalmoscope. And I look in each eye and look for a red reflex. And that's just showing me the retina in the back of the eye and that there's not any cataracts or any masses in the eye or anything like that. And then look in the mouth. Make sure that there's not any cleft palate or there's not any... I know.
Oh, baby girl.
I hear you. Not any abnormalities in her mouth or a what we call tongue-tied. Mm-hmm. Tongue-tying it's a fairly common thing, and that's when the tongue is tethered a little bit closer down and they can't really stick their tongue out. If that happens, they have a really hard time latching on and eating. So if ever mom is feeling like they just don't latch, they just don't suck, we look for that. And if the baby is tongue-tied, we'll talk to ear, nose, throat doc, and they can come in and they can clip it, and then it'll move easier, and then they'll be able to eat better.
And it can also affect them as they get older with speech
Absolutely.
and sucking, all that kind of stuff.
And it sounds, talk about clipping a part of the tongue, it sounds kind of scary and painful, but it really is a very simple, and the babies really take it just fine, and it's not a problem, especially if we catch it earlier in progression.
Well, thank you so much, Dr. Delgado, for spending some time with us today. And thank you to our star baby, Ellie. She's adorable.
Sweetheart.
If you guys have any questions for me in the future, you can ask them on our Facebook page at facebook.com/Intermountain Moms.